60-year-old lady presented to OPD with complaints of bleeding per rectum and growth near the anal region for the past 3 years, and loss of appetite and loss of weight for the past 1 year. Initially, she had history of bleeding per rectum, initially associated with stools around accounted for 50 to 100 ml as reported by the patient, which has increased over the past 1 year. She observed a growth 1 year back, which was initially a small swelling near the anal region, which has now extended and is involving the perianal skin as an ulceration. She also complains of loss of appetite and loss of weight, which she feels as loosening of clothes for the past 6 months. There's no issue of jaundice, there's no issue of any decrease in output, or there's no issue of any other swelling in the body, sir. And on examination, sir, patient is appears emaciated. She has pallor, and her pulse rate was around 80 per minute. Sir, on per abdomen examination, there was no lump palpable and there was no signs of ascites. On external examination of perineal region, there is an ulceroproliferative growth involving the perineal region of 18 to 6 centimeter with slough present over the floor. On further examination, so there was bleeding on palpation. There was bleeding on palpation, and on further probing of finger into the anal canal, there was a constricting growth present throughout the anal canal, sir. Upper limit could not be appreciated.
It is. What is its relationship with the vagina? Is the vagina all right?
On anteriorly, it appears to involve the posterior wall of vagina, sir. She didn't give consent for PV examination to appreciate it.
But through the rectum, you could appreciate that.
Yes, sir. And on further examination, we look for lymphadenopathy. There were bilateral enlarged lymph nodes, mostly on the right side, sir.
Which lymph nodes?
Bilateral inguinal lymph nodes, sir. And then of size 2 to 3 centimeter largest.
Consistency?
Consistency of permanence.
So basically, looking like a case of, we've seen the case, so it's a case of carcinoma of the anal canal, and we usually call it anorectum. Anything specific that you would like to take in the history, anything more? Do take history of, high risk behavior. It's common with HPV now.
Yes.
And you must take that history in all these cases. The other thing you need to know is whether the patient has got incontinence or not, because that would be a feature of involvement of the sphincter. I would be surprised if there is no incontinence, but very highly likely. Naturally, the patient goes in for your history and examination is fine. The patient goes in for, like I say, for all malignancies, it is T, N, and M. So history of T, N, and M you have taken. Examination you have done for the 3. For the M, you need to investigate. So you need to do an ultrasound abdomen to exclude ascites, liver metastasis, etc. Inguinal lymph nodes involved is a part of the disease, but they could many a times be reactive also because it's inflamed and secondarily infected. Now, what is the usual approach? We do the investigations to confirm the diagnosis, to support the diagnosis, to stage the disease, and to treat the patient. To confirm, we did an edge biopsy. What is the report of the edge biopsy?
So it turned out to be squamous cell carcinoma, moderately differentiated.
So based on this histopathology report only, we call it anal canal because we can't make out. So we don't know whether it started in the rectum and came out, or it started in the anal canal and went back. So we call it. They all called as therefore cancers of the anorectum. And squamous cell carcinoma is usually the type. So what is the sanctity of dentate line, Ishita?
Sir, so the blood supply above the dentate line and below the dentate line is different. Like above is superior, mesenteric and below. And sir, originally.
Not Mrs.
Superior rectal and inferior rectal. And sir, the origin also is different.
What is the difference?
Dentate line, the lymphatic, and the arterial supply and the nerve supply is different above and below the dentate lines. Above it's the rectal, superior rectal artery.
So basically, I think they're mixing up. So it is a watershed area. So the blood supply above the dentate line is portal, below is systemic. So it's a porto-systemic junction. That is why you can get those piles there, which are portal piles, like portal Total hypertension can produce those points. They're different from the hemorrhoids, right? Then above the dentate line, the nerve supply is autonomic, so you have no pain there. But below it is somatic, so anal fissures are painful, hemorrhoids are painless. So that is how you differentiate the two. Hemorrhoids are painless unless they are strangulated or they have come down below the dentate line by when they become grade 3 or grade 4. Then the lymphatic drainage above is following the blood supply. So it will go along the portal route to the, that's the direction it will follow. Even if it goes along the rectal, so rectal is a continuation of the epimesenteric route. Comes to para-aortic and that's the route. But the one below the dentate line, the lymphatics will go to the inguinal lymph nodes. And the usual presentation is the epithelium below is stratified squamous epithelium, above is columnar. So you'll get adenocarcinoma above and squamous cell carcinoma below, which is what you've got here. So based on that, the management is totally different. Above it's primarily surgery, although you can do chemoradiation and surgery. But anal squamous cell carcinoma is classically managed by the Nigro regime, which is chemoradiation on a mitomycin based chemotherapy, followed by salvage surgery if required. And for putting the patient on that therapy, you need to divert right now. So she would require a diversion colostomy, and that would be followed by the chemoradiation. That should be our protocol. But we should do a metastatic workup, and we should have the complete workup done before we plan the patient for this. But diversion is, I think, required. That's the least you can do in these patients.